Hello, I'm Matteo Simonetti, multimedia producer at The Lancet, and I'm here with Chloe Wilson, senior medical editor at The Lancet Weekly, to talk about a new podcast called The Lancet Pulse. Hi, Chloe.
Hi, Matteo.
Tell us something about this new channel.
Well, we're launching this new podcast, The Lancet Pulse, on February 23rd, and I'm really excited about it.
Yeah, me too.
In the Lancet Pulse, editors are going to be joined by subject experts to discuss some of the hot topics in medicine. And it's supposed to cover a really broad and diverse range of areas. Think artificial intelligence, psychedelics, xenotransplantation, just to name a few. And it's not necessarily related to a piece of content that we've published, but instead it's supposed to break down what could be quite complicated or controversial areas in a really engaging way. And not just through discussion from experts, but also through discussion with the editors, highlighting what's upcoming in that subject area, as well as some key takeaways from the discussion with the expert.
Thanks, Chloe, for this introduction. For our listeners, you can search for The Lancet Pulse on your favorite platforms from February 23rd and join the conversation.
Hello and welcome to The Lancet Voice. I'm Chloe Wilson, and today Jessamy, Bagenal and I am joined by Mumtaz Patel, President of the Royal College of Physicians and consultant nephrologist, to talk about workforce and training issues in the NHS. So it's December 16th, and I just wanted to start this Lancet Voice where we are joined by Mumtaz Patel, which we're very excited about, to give you a bit of background about what the current situation is in the UK. So the 14th strike by resident doctors in England is due to start tomorrow. But setting out the context for our listeners who are maybe outside of the UK, we do have a devolved government in regards to health. So this is just going on in England because there have been agreements in previous years related to Wales, Scotland and Northern Ireland. And it's a very difficult time at the moment because public support for the strikes is actually quite low. And there's been a strong rhetoric because we have winter pressures with increase in numbers of people with flu that the doctors are actually abandoning patients among the winter pressures. So given that introduction, I really wanted to pass it over to you now, Mumtaz, to ask you, so what is going on with junior doctor strikes? Is it just about pay? Is it about something more?
Thank you, Chloe, for the kind introduction. So I think a lot of these issues are wider. So the current situation within the NHS, as Wes Treating described it, it's broken, it's really hard. The demand versus the capacity issues are really difficult. And day to day, number of challenges. We've talked about, winter pressures being all year round, and also corridor care, which we've talked about quite a lot through the college work as well. So all year round pressures within the NHS, and workforce is integral to a healthy running of the NHS. The recent lead-in and the issues around the strikes, I feel, are very much deeper and much more wider systemic issues. As a Royal College of Physicians, and we're not the trade union, so we don't specifically get involved with the negotiations around the strike. But what we do get involved with our resident doctor committees and our Next Generation campaign is getting the situation right for our resident doctors. So the rising competition ratios, the recruitment issues, the retention, the workforce well-being, wider issues, the training which doesn't work, and the reform of training that we've been asking for. So a number of system level issues which we are concerned about and are wanting, advocating for our resident doctors. And value, everybody wants to feel valued within the roles that you do. And if you don't feel valued, the morale gets really low, which sadly is an issue currently also within the health sector.
So the latest deal that I had seen that was offered by Wes Treating, some of the aspects are in that. So they said that they were going to try and increase training numbers by 4,000, with 1,000 specifically for 2026. And for our listeners, I mean, is there a shortage of training places? And you mentioned competition ratios. So what's going on from that side of things?
Yeah. So again, there's the training post, the doctors in training, which is the posts that are under NHS England in England and NHS Scotland, those kind of governed and quality assured posts, and that leads into sort of specialty training posts as well. And then there's lots of locally employed doctor posts, which are trust funded, hospital funded, and more like locum posts. And again, the quality assurance of those posts may not always be there. So with regards to the competition ratios, the issue is within those doctors in training. So the doctors in training and the training specialty posts have stayed stagnant for a number of years. And despite the doubling in the School of Medical School places, which is what we campaigned for some years ago, the commensurate increase in foundation core specialty training posts hasn't happened in that way. So I remember being in my other posts previous to my president role as postgraduate associate dean, and the expansion of medical schools were happening. And there was really little consideration of, in 5 years' time, these people will need foundation posts and core training posts. And that kind of bottlenecks was just already heading towards that. We got further increase in medical school places during COVID. Boris Johnson promised some more posts. There's lots of private medical school posts as well, and medical schools which have come. So the rise in competition, as well as the removal of the resident labour market test. So post-Brexit, there was concern that we will have workforce shortages and rota gaps. So the resident labour market test was removed. So that competition went away in the sense of, open to all with regards to recruitment. But that meant that these competition ratios of people applying and then just not getting posts. So I've spoken to a number of our UK graduates who have gone to Australia to get more experience, come back to the UK, applied first time round, applied second time round, and still not getting into the system for the specialty training posts. And that's really disheartening that they've put in so much hard work and effort into getting into training posts, and they're stuck, and loss of talent of a whole generation I worry about, because it's year on year we're seeing the same things.
It's interesting, isn't it? Because I was speaking with colleagues the other day, no names shall be revealed, but they're older generation doctors, very high profile. And some of them were saying that actually what they felt was the issue was that people were less willing to travel to get places, that there wasn't a shortage of training places, but that generationally there was a difference in what people were willing to do to be able to get those training places. So, in my generation of doctors, it was very normal that you would be separated from your partner during your training, and you hoped at some point that you would be able to get a training place together. And their point was that that's not tolerated anymore. Is there any truth in that? Or is this a kind of slightly unpleasant generational kind of stigmatizing of medics?
Yeah. No, it's hard, isn't it? And I think the training systems currently are very inflexible, and the rotational training. I mean, I moved 14 houses, 14 places or flats over the course of my training. And despite getting married, I didn't have children until very much later. And, work-life balance is a real issue. And, generationally, yes, I feel that, these things shouldn't be accepted as a norm. And, flexibility is absolutely key. I mean, my progression wouldn't have happened if I didn't have the flexibility and support of my peers at the time. With regards to numbers, yes, in less popular places. So I live in the northwest of England, and we always say, certain places, Blackpool, Barrow, coastal regions, deprived regions away from the cities are always more difficult to recruit. That's been the case 20 years ago, 30 years ago, and sadly still remains the case now. However, what has significantly changed is those proportions. So, when we had, when I was looking at the figures in 2019, there was 12,000 applicants for 9,000 posts. Now we have 39,000 applicants for the same number of posts. So, that has significantly changed. So the training posts are the same. The locally employed doctor posts, those have tripled, so those have gone from say 11,000 to 29,000 or around that number for over the last 5 or 6 years. But those are not, helping progression. So those are like, you're stuck in a way, and people are sadly having to opt to do that because they can't get into the training specialty posts. So I think there is still a number imbalance, and those difficult to recruit areas sadly still remain difficult to recruit. So there's some places in Wales, I think they are still underfilled, some places in Scotland which are underfilled, but I feel proportionately that bit hasn't changed from what it was 30 odd years ago.
And just to kind of explore that a little bit more, I mean, how have we got this so wrong? Because we are all familiar with the problems of the NHS that, you know, lots of as a system it's facing, but also individual clinicians and healthcare professionals, the sacrifice that they make, the pay that they have received is not commensurate to the role that they perform. And then on top of that, layered on top of that, we have this sort of what feels like an injustice, because one of the key things that you were always told as a doctor is you'll always have a job. Like, yes, you might not be earning as much as you could do in the city, but you will always have a job and you are secure, you are safe, and, you know, you can rely on that. And what it feels like, whether that's correct or not, but, you know, you go onto Instagram, you go onto TikTok, you go onto any of these social media, there are GPs crying there, saying they're being made redundant. And this feels just such a grave injustice. How have we managed to get it so wrong?
I know, it's awful, isn't it? And I think, you know, kind of that kind of lack of foresight and the workforce planning and modelling aspect side of things. I know it's really hard, and all these things are always easy in hindsight. But some of the things that I mentioned before, you know, if you're doubling the medical school places and, you know, sort of promising 15,000 places by 2031, surely you should be thinking that we need to be increasing the number of training places going into postgraduate training. And that, you know, for us in the system, hasn't happened in that way. You know, we've been pinching and trying to find the posts for the expansions as they happened. The resident labour market test being removed, yes, appropriately perhaps at the time. But again, I feel lack of foresight that we were going to get flooding of a number of, you know, kind of international medical graduates applying. And that's absolutely fine. It should be equity and fairness for all. But having said that, there should be fairness within the system to accommodate if that's what we're trying to do as well. So I think perhaps, you know, the workforce planning, and I think there's an opportunity now with the 10-year workforce plan, and we've been inputting a lot into that to say, just think about it, you know, and based on population need, because where the population need is greatest, that's where our medical workforce needs to be. So, you know, Manchester, London, big cities, yes, you know, the big populations, but particularly also the wider, you know, kind of regions away from the centre, more deprived regions. And that's where the health inequality kicks in even more so. So it's making sure it's fair across for the population need.
Yeah, and nobody's saying, are we, that this is easy stuff? Because actually it's incredibly hard, because this relationship between medical schools to training places to consultants, the fact is you might be able to increase training places each year by, you know, thousands, but ultimately the country doesn't need thousands of consultants, nor can it afford thousands of consultants becoming consultants each year, who then essentially sit in that job for 28 years or for 30 years doing the same role. So we have somehow managed to create a system where the only measure of success is becoming a consultant, and everybody else who doesn't do that feels like a failure. And also all of our incentive systems are also geared towards that. So you start earning more, you start having flexibility when you're a consultant, you can start doing private practice. In many ways, some people feel like that is when life begins, when you become a consultant, which for some people might be training for 20 years, you know, and then suddenly, oh, I can actually be in control of my rota and my schedule, I can be in control of my time. How do we change this? Because it's not sustainable. We can't live in a world where the only measure of success is a consultant, because one, we then get this type of problem in training places, but also we just physically don't need that many consultants. And, you know, we're hear lots about innovation in AI, and hopefully that will reduce some of the administrative burden and help workflow systems. So what does that look like, that sort of reimagining of what a medical life in the NHS looks like?
Yeah, no, completely, all fair points. And what we can't do, certainly with even the bottlenecks and the current situation, is just move things down the line, because that's not right either. Because, you know, as you say, the need for perhaps that many consultants is not needed, but then there is certainly need for more GPs, more psychiatrists, more specialists, but also generalists, because we push a lot because our aging population, you know, people are living for longer, rightfully so, and we welcome that and we want that, probably even for ourselves in years to come. But the complex needs of the patients is more of generalists. So we need to make sure that we're training in the right way. A number of the doctors are not on training pathways, like I was mentioning before. Locally employed doctors are SAS colleagues. Many of those are international medical graduates, and they've made an active choice to be, and many of our UK graduates are also making an active choice to be in more SAS kind of posts and specialist posts or generalist posts because of, you know, their own circumstances. But we need to value those posts as well. We need to make sure that those posts also have, you know, not just pay progression, but progression from a career perspective. They're supported, they're valued, and they're not just seen as gap fillers. I used to hate that term when I was, you know, and even now when I go and it's that rota gaps, we need to fill it. And it's like, what's a person, you know, and a person needs to feel valued and supported. So I think it's the balance between the different roles. I don't think everybody even wants to be a consultant, and, you know, having been one for 18 years, it's hard work as well. I think it certainly increases challenges as you become more independent. So getting the balance right is important.
I was just going to say, because we were talking about SAS doctors, because I worked as a specialty doctor in cystic fibrosis for 18 months. And I think one of the challenges with doctors that aren't in training per se is that often you, as you said, you can just end up filling the rota, which means you don't get any of that dedicated time to read journals, you know, to do trials. And for me, when I was working in cystic fibrosis, it was very easy because there was a strong emphasis on doing the academic side of things. But I don't think that is the case among all SAS posts. And I think that's a big part of people's job satisfaction. I mean, we see it with GPs. Most of the people who are GPs that are happier are those who are a GP with a specialist interest, or they have sessions where they're doing something else outside of the clinical workload because it's so heavy. So what are we doing to make sure that doctors in those posts have more time that's protected to do those things outside of the, you know, the high clinical workload?
Yeah. So again, within the Royal College, we have a number of our SAS doctor colleagues as well. We have a SAS lead, a committee. We have regional representation. We were in Belfast recently and in Cardiff, where we have a lot of SAS LED doctors. And as a college, we want equity and fairness across. Yes, you know, it always seems that, you know, kind of, there's no training, there's no career progression. And unless there's local support within a hospital or a trust or even a department level, sadly, it doesn't happen everywhere. So how do we take away that variation of quality and support and make it more equitable? So those are the kind of things, you know, we've got the SAS Charter, we've got our SAS strategy through the college, we provide that support. We've put forward some guidance last year around support, supervision and fairness and progression. And it's autonomous practice. How can you support and value that in that way? And then there's national initiatives as well in order to do that as well, through the NHS England and wider also from the medical training review. So I was really pleased to see from the diagnostic medical training review Chris Whitty and Steve Powers produced, they specifically had an area of supporting SAS doctors, colleagues, locally employed doctors, to make sure that that quality and fairness is there. And they're not just the gap filler. I hate that term, I really do, but sadly it's used, isn't it? And unless the department, you feel, invests in it, it doesn't happen. Whereas I feel that if there's some quality standards that people need to adhere to, and people will be accountable for providing that quality and support and supervision, then we can ensure that. And people who choose to do that, even our UK graduates are choosing, like yourself, you know, I even also did, I think about 9 months in a renal standalone post before I got my training number. But if you are choosing to do that, then that should be a supported, quality assured post. And that's what we're pushing for as a college as well, as part of the medical training review, hopefully going forwards.
going to say, how much do you think those national initiatives actually work? Because even within an area, it differs so much locally. And I think that's one of the really huge problems. And that's one of the big problems that we have across training, because we have these areas that are difficult to recruit. And it's often because people who live within an area, because so I came back to Wales to do my foundation training, and I'm from Wales. And often people who have gone to medical school in Cardiff or Swansea will stay in South Wales, but you don't often get that many people that then move into Wales. But even within those areas, you have certain hospitals that people don't particularly like to work at. So I just wondered, it's great to have the national initiatives, but how can we make sure that those actually work at a local level?
Yeah, no, absolutely. And I think, even the variation is great. I mean, I did the postgraduate associate dean role for some time. And even as college now as president, we do a lot of regional visits to look at quality of training, but also quality of the SAS and the other posts and the educational environment, because the environment is key. And how do you make it better? Because one hospital down the road might be doing it very differently. So making sure some of these national initiatives, then you're working with NHS employers, the trusts, and then ensuring that there's quality standards to measure against. Because I do feel sometimes, like the top 10, kind of markers that came out for quality from NHS England recently as well. They did a league of the trusts in our region in the Northwest. And it's very evident if you're not meeting some of these standards. I mean, some of these things were just getting your rotas out in the right time, making sure that those rest facilities, all these kind of things. And I think ensuring that you're a bit of a carrot and stick approach, that there's reward for those who are doing fantastically well, because that gets under recognised. Some of the trusts and departments work so hard to ensure that there's maintained quality and support. And then in other ways, when there isn't, I think support to be provided to enable that to happen. I don't think anybody wants poor working environments or departments. So making sure that we also advocate for them, whether it's for funding, whether it's for resources, to ensure that quality. But it's hard. I think the top-down approach has some merit, but then the bottom-up approach and making sure that you're learning. We pair a lot of trusts together sometimes where we've heard areas of good practice and there's some learning. So in the Northwest, within different hospitals where we've heard challenges, we've paired them up in like a buddying system for hospitals and departments. So there's cross-learning and hopefully support within that as well. Because we appreciate it's a pressured environment. Nobody is wanting to make it a bad or a failing hospital. It's just sadly the situation that we're faced with.
Yeah, I mean, it's one of the other things that we talked a little bit about retention, but I do think it's an area that we probably don't talk about enough, because I think we can all agree. I mean, there's more than enough work to go around for everybody, but we're always talking about increasing numbers. But I feel like there's often not very much emphasis on retaining the people who have already come through the system. I mean, when I left general practice, I didn't even have an exit interview. It wasn't even on the radar. And I know that's not the case universally, but I've heard it across a lot of people. Many of my friends, I mean, almost all of them went to New Zealand, Australia. In part now, I think part of it is to get a job, but it's also the work-life balance. And it feels like we talk a lot about resilience, and I've come to hate that word almost, because it feels like almost that it's a problem with you personally rather than the system. But do we think that any of these issues on getting your rota done, actually just improving IT equipment? We've got many of our hospitals are actually crumbling with the infrastructure that we have. And we're talking about things like AI revolutionizing work systems. But most of the time, you still can't even get a computer on the ward. So I'm just wondering, what it feels like those sorts of issues are often just really ignored. And what are we doing, or are we seeing any progress to make that better?
Yeah, no, so definitely we as a college, and even in my own experience, I mean, I think the recruitment and getting the pipeline bit right is one aspect, but we need to retain our staff and also the workforce well-being. We need to make sure that when we do have our staff in the post, they are well looked after and supported in those roles. So a lot of that, I think, comes down to, and as you rightly said, people leave to go to Australia, and I've spoke to quite a few people, even in the last few weeks, of those those who didn't get, say, an IMT interview or whatnot. And they said, when they went to Australia, New Zealand, work-life balance was amazing. They were doing less for more as far as work versus what they were being paid for. And the investment in the individuals is so important. I mean, I feel that if you value someone, if you make them feel that you're interested and you're supporting them through their career progression and a wider support aspect, then that really, really helps. But from a system side of things, a lot of our current medical training systems have been outdated. The flexibility is just not there. The work-life balance isn't really addressed. And going back to both of your points of, we're just made to somehow get on with it and be more resilient and somehow deal with it and have our children later or whatever, rather than having a system that is adaptable and works for people. And I think this generation, certainly my children, won't accept the kind of things that I had to go through 20, 30 years ago. So we need to make it fit for the future, the current working of, kind of our resident doctors and for all the workforce, I feel, because the NHS is based on goodwill. Goodwill's running out. And I think we really need to kind of invest more in those basic things. I always say, even to government, that it always takes me half an hour to put my computer on at the hospital. No chance, go make a cup of tea and come back and it's still doing its thing. But, all this AI and digital transformation, amazing, but the basics are just not right. Rest facilities, getting food, kind of the sandwich machine that just doesn't work at 2:00 in the morning when you're trying to get something to eat. I mean, surely it just feels really wrong. So those are the kind of things that we're pushing for at a system level. And yes, we're investing in it from a Royal College perspective, but then working with our key stakeholders and partners. So for us in England, NHS England, big partners with regards to delivery, the medical training review aspect side of things, getting the basic rights with the NHS employers. And we give the resident doctors a voice. So a lot of our resident doctor chairs meet with the key, kind of Chris Whitty, Meghna Pandit now, it was Steve Powis, kind of every few months so that they can put forward their voice and we can advocate for them, because I think that's important for your voice to be heard and then also understand where the challenges are. So I know those kind of meetings have been helpful to us say, okay, that's NHS employees, that's this person. So we need to make sure that we're addressing the concerns to the right people as well. So I think a radical reform of training is what we're pushing for, getting the basics right for our residents, but all staff on the ground is really basic, but just needs to happen. And then, with regards, burnout, all these things, we wrote a paper for the Lancet a few years back around the COVID time, which looked at burnout and moral injury, because that's so real. And it's not, again, giving you like little huddles to go to or your coffee mornings or something. That's not going to sort out your well-being huddles. It's the system level issues. And I do feel well-being should be a key quality marker for all trusts, for all organizations, so that these simple things can be done, could be monitored. And then it's not your fault as an individual. It should never be centered on this individual. It should be how the system and, the trainers and we can support you better on the ground to make it better and more manageable. Otherwise, we will have no workforce. So recruitment is one thing, which we've talked about, but the retention and the well-being, because morale and burnout are so, morale is really low and burnout is super high. And that's not because people are not coping this generation. It's just because it's really rubbish and, really difficult to manage. Sorry, simplistic terms, but you know what I mean.
No, it's true, isn't it? And as has been much discussed, the nature of healthcare has changed so much, and the responsibility, the liability, the pace of things, it is different. So I think also there's, it's so wonderful to hear you speak and also to know that you're at the Royal College of Physicians trying to kind of push this agenda forward. But I know that there are a lot of young doctors who feel kind of left behind from an older generation who, were able to buy their house, were able to have more flexibility or at least more autonomy to be valued as a profession, much more. And didn't have all of these kind of the same pressures that they have. And so it really is our duty as a healthcare group to make sure that we can look after this younger generation and show them what a wonderful career medicine can be, because it still remains a great career and there's still so many options that it gives you. But right now, when you're on that, cold face doing it day in, day out, it often doesn't feel like that. We must try and save that. It's so important.
Absolutely. And it's how we harness that, because I still feel medicine is brilliant. I mean, I've been qualified for, nearly 30 years, showing my age. But, I still think the diversification of what you can do in medicine, and what I try and do is instill that early. So you don't have to wait till you're a consultant to start doing different things, developing that portfolio kind of career. I know people, even medical students, ask me, Mumtaz, how can we do what you do now? And it's like, well, get into this and do this leadership stuff and get into these roles early, because I think then you can see the breadth of medicine more, because I think people are just really, kind of get fixated with the doing and all the pressures, because the complexity of the patient expectations has changed. You're no longer God. My grandfather was a medical officer in India and he was treated as like, the person to look up to. And that's all gone. I mean, the societal expectations are very much, you're having to really fight for your corner, for your patients, for doing basic things day to day. And it feels like a battle, and you shouldn't be feeling like that. And that's where I think the burnout comes, and the reward. I still feel, I love, seeing my patients and the individual gratification that you get from that. But because of the lack of continuity, you don't see the same patients in early career grades. You don't get that continuity of care and that feeling of value, which works both ways. So there's lots of things in the system that need to be addressed and fixed. I'm not saying, it was wonderful 30 years ago. It wasn't, far from. But certainly, it feels harder now. And we need to be advocates for our next generation. And our campaign has been amazing. So our Next Generation campaign, which supports both doctors in traditional training pathways, as I call it, and non-traditional training pathways, which includes our SAS doctors, LED doctors, IMGs, and it's supporting them through the challenges through their lens. And they came up with 19 or so priorities. We're working through that and advocating to improve the quality of their lives going forward, so we can keep them in the system, because it's really important to both retain but also make them see the joy of medicine, because I still love what I do. I know it's hard and I don't always have good days. I'm sure we all have good and bad days, but broadly speaking, there's very little else that I would do. But whether people want to get into teaching and training, leadership, management, research, we should be facilitating that and accommodating that. I know you wanted to talk about research as well. Again, there's things that people get value from and feel that, oh, this is my I'm good at this and I want to do this. So we need to enable people and support them so that they can fulfill those areas of interest as well.
Do you think we need to recognise that opportunities to step outside of the more traditional pathway do you feel more limited than they used to be? I was looking at some, because I'm quite interested in the clinical academics, because I think that differs hugely across the UK. I think, often it depends on your links with the particular university, but some of the numbers, so only 1/3 or more than 1/3 of all clinical academics are over 55. So that we're going to see that there will definitely be less clinical academics, but also in the UK, our universities are struggling. We've seen it across the news, even with some of the Russell Group universities, that financially they're not doing as well as they used to be. I mean, it's a global problem with funding research, but I think that we should be doing a lot more to support those sorts of pathways, because we know that often having a diverse career and being able to do those additional things is really important to maintain somebody's well-being at work and find the joy in what they're doing.
Completely agree. And I think those kind of things with the research and clinical academia have been, kind of dropping off. And we saw the Chinnery report. There's lots of national reports looking at the numbers around clinical academic training pathways, and also the stepping in and out. So when I did my training, I went out of program to do my research, and I had support to do my pilot study, which got me some funding and some papers so I can apply for funding for my PhD. But there was flexibility for me to do that. The clinical academic training pathways are amazing when they work. The partnerships between the universities. So I was NIHR lead in the Northwest for the last, 8 years or so, and supporting and seeing people through within those journeys was fantastic. However, as you rightly say, the funding for universities is going down. The funding within hospitals for providing that 50% or whichever support, depending on the pathway from ACFs to ACL posts, is dropping, and service provision trumps, kind of any kind of training pathway, which makes it really, really hard. And also the variation of the funding, as you rightly say. So, I know in my day, it was very London centric and, kind of Oxford, Cambridge and up north, it was so limited. And even like Wellcome Trust funding and big funders that you'd go for, they'd look at the place. I was always told, the supervisor and the project, and the place normally trumped, as in, kind of if you're in a big, huge centre, you're more likely to get funding. So what we as a college, we've always supported clinical academia, but academia per se, for supporting development of clinical academics, time for training, and time for supervision for consultants to supervise. So I still supervise my MD PhD students, which I really enjoy, but making sure that that time is carved out. And we've had discussions with government through the college roles for me, as well as, kind of other partners. And again, I was pleased to see that it was within the diagnostic report of the medical training review as well, with regards, clinical academia should be supported. Because, if we've learned anything from COVID, I mean, the research innovation side of things is absolutely crucial. But from an individual level, it brings joy to people. And if that is their area of expertise, again, we need to nurture that talent rather than losing it. And again, the last point would be flexibility. So somebody who's a woman with children, again, these pathways are not always supportive of people wanting to have a good work-life balance, and we having to kind of fend for that. And a lot of people drop off who are really, really good that I've personally seen. But I try and keep them in the system by that kind of the support, the mentorship, and making sure that their progression is enabled. And even if they choose to work less than full time, that should be acceptable, and we need to work around that. So I think lots of different areas that we can promote. And as a college, we promote that flexibility, support both the clinical academic training pathways, but as part of the medical training review, the NIHR post is one aspect, but we should be supporting even the local research as well, because there's some really good local research training, and the partnerships between universities and also the hospitals needs to be strengthened, because I think that's got weaker over time because of different pressures of funding. And again, not pumping just lots of funding everywhere, but the right funding in the right places and the right partnerships to be nurtured as well.
It's been great talking to you, because it does feel reassuring to know that there are people who do really care about the resident doctors and SAS doctors, and are working very hard to make the current system better. It's just difficult because that isn't an easy fix, I think. And often when it's talked about in the news or by politicians, it's presented as if that is an easy fix, but it's something which is, it's long over the lifespan of a politician or a particular party in the lead. But it's something that you just hope, because it feels that we've just chopped and changed plans so many times, that we just need some continuity to make, the training pathways better and realistic for what life is like today, and the actual pressures in the system that are very different than they used to be.
Because that's the thing. I think what people forget is that we're in changing times as well, and things need to adapt with the changing times and the expectations of people around us. And, we truly, education training is my passion. As I'm sure you can see, it's something that I'm really invested in and I want to get right. And I think for the as I always say, that you inspire others by the journeys that you've had. But unless you learn from the things that didn't work, and you try and make them better for others to follow, it's not going to be the same for others to follow. So at a system level, I'm very privileged to be in that position now, to be able to drive that change, or at least push it in the right direction. And that feeling seems to have gone away sometimes, because I hear lots of key leaders speak, and there's, it becomes a bit political rather than, actually, as you say, caring about what the right thing is there to do. And it is complex. It's not an easy fix at all. But I think the small changes can make really big differences. And even just having a good mentor. I mean, if you have I was really blessed with really good mentors and supporters who made things happen, and I think even at an individual level, you can really make a difference. But what I'm trying to do as president of the Royal College is do that in a systematic way and make sure that translates onto the ground in making a positive difference as well.
Yeah, thanks, Mumtaz. And I mean, just to finish, because we have talked about essentially a total reimagination of training in the UK, and the necessary changes are large and complex. One, do we have a government that has that kind of appetite? And two, what we need here really is a movement, don't we? We need a consolidated, large movement to be able to define what that transformation needs to look like, and then be able to implement it. And it's going to cost money, if there's going to be so many barriers. How can we start that movement? That's what we need to do, right? It can't just be you at the Royal College of Physicians. It has to be lots of people together. Are there people trying to bring that movement together, or?
Yeah, no, absolutely. So I think, fair point. And I think I always try and see it as a, kind of opportunity and half glass full kind of approach. And I think it is an opportunity at the moment with the medical training review. The diagnostic bit is good. And I think it has a lot of the areas that we want to see. The devil's in the detail and how you translate that into solutions. The resident doctor voice is absolutely key. We can't not listen. And I think, you have the solutions. You're part of the solution. So we need to make sure that you're heard within that, because what you will tell us, we need to try and then find ways of making that happen. So making sure that in the phase 2 of the medical training review, that resident voice, doctor voice remains strong, that we can develop, co-create the solutions, co-create the model that we feel is going to work, and be ambitious. And then we have to be realistic as well of what can be delivered. And it could be short, medium, longer term, kind of goals, that we've kind of do some of the quick fixes that need to happen quickly, some of the infrastructure stuff that we've talked about. Then we look at the medium, sort of level, sort of training changes, the burden of assessment, how training works, adopting the flexibility, and then the longer term things, which may take longer. But if things are moving in the right direction, you'll keep people with you. So we'll continue to advocate as a Royal College. The Academy of Medical Royal Colleges are brilliant as well, and they're a really sound voice. We go to government with themes now. So rather than saying we at RCP are most important, we go as the Academy of Medical Royal Colleges are really worried about workforce. We're really worried about health inequalities. Please look at this. Please try and address this. And we go with solutions rather than just telling people the problems, and the solutions come from our resident doctors when it comes to training. So I think working together, collaboration, co-creation, involving our resident doctors will be the way ahead, which is slowly happening, and we're strongly pushing that and advocating and facilitating that as best as we can from our end.
Thank you so much. It was such a pleasure to see you, Mumtaz.
Thank you.
Thanks so much for listening to this episode of the Lancet Voice, and we hope you enjoyed it. If you're interested and want to find more of our podcasts, you can find them at thelancet.com/podcasts. Thanks for listening.